two screens, so I thought if you have a mouse, you can. You don't have a mouse. Okay. Chairman, the first good news is I'm going to finish in 10 minutes.
Yes,
That's
sir.
the duration of my talk.
Oh,
The second
great.
thing is I have not taken any honorarium from anybody for giving this talk.
Very nice.
And the third point is my summary slide is sulfonylureas are still one of the best drugs we have in India, and it's still not time to crucify sulfonylureas. With this introduction, I'll make my 10-minute presentation.
Thank you, sir.
Let me start with a tribute to my father, Professor M. Vishwanathan, who started the first hospital for diabetes in India called the MV Hospital for Diabetes, which has now become a WHO collaborating center for research, education, and training. And in the first three slides, I'm going to show you some of the patients whom he had seen in 1960s who have been followed up until 2013 and show you their performance with sulfonylurea for the past 30, 40 years. And for the sake of this presentation, I digged up a few of my colleague, Dr. Sabita, and I digged up some of the patients. We had a big set of patient data set, but I took about 48 patients and then 6 patients who had taken sulfonylureas for about 40 years. So what I'm going to tell you in the next 2-3 slides is how did sulfonylureas behave in these patients in the pre-Gliptin era, even before the world had actually known what Gliptins was all about. So for the sake of this presentation, my colleague and I, we dug out the data sets of about 48 patients who had been registered from 1965 and who had about 25 years of follow-up in our institute. And for the sake of this specific presentation, I took 6 patients who had been started on sulfonylurea with or without metformin in the 1965 and followed up till 2013. And there was a mean follow-up of about 35 years in these patients. And their mean age at onset of this follow-up analysis, which we did, was about, their mean age was about 39 years. And A1Cs was actually measured in our institute from 1983. Before that, it was HbA1. So I did not take that. I took HbA1c because that's the gold standard now. And this was the baseline A1c at the time of the study period when I really looked into the data. And you can see that until 2013, these patients are still on sulfonylureas, and you can see their A1C with or without metformin, and you can see their A1C is still 6.9%, and you can see the A1C progressively coming down, and therefore they have still been on sulfonylureas even till date, and they are quite healthy and doing very well, with no big episodes of hypoglycemia and so on. Therefore, this brings us to the question that do sulfonylureas have a role? Do they have a role in type 2 diabetes? And the NICE guidelines recommends sulfonylureas as a first-line option for non-obese patients or patients in whom metformin is quite inappropriate. And in patients in whom a rapid therapeutic response is needed is yet another prominent group for whom you could consider sulfonylurea even without metformin to start off the treatment of type 2 diabetes. Therefore, it represents a well-established and flexible class of glucose-lowering drugs. Now, what does the ADA and the EASD say? They definitely have sulfonylurea quite high up in the options. And if you take, in terms of efficacy or reduction of A1C, it's quite high. Hypoglycemia, of course, is there. And if you use some of the agents which I'm going to tell you about in the next few slides, probably your hypoglycemic risk is not all that great. And weight gain is there, of course, if you use sulfonylureas injudiciously and push your patient into repeated hypoglycemia, that could result in weight gain. Hypoglycemia, of course, a side effect, but we have to use, as I said, quite judiciously. But the important point in our country to remember is we have a huge burden. We had published a paper in the Journal of the IDF 2-3 years ago that the cost of diabetes care in India is $31.9 billion US, which is about 12,000 crores Indian rupees. So I think no government or no individual can afford costly drugs if something like a sulfonylurea should work for a patient in India, especially in rural India. Whereas if you take drugs like Gliptin, they are very good. You can see that there's low risk of hypoglycemia. They're weight neutral. They do not have much of side effects, but this is probably the factor which we need to consider in developing countries like Africa and India, the cost. Now, if you take the IDF guideline, I have been in the guideline of the IDF Global Guideline for the kidney, along with Sally Marshall, the IDF Global Guideline for type 2 diabetes. The IDF Global Guideline says that you should consider sulfonylureas as a second line, and it is quite a priority. The blue area represents the usual approach, in the dark blue, and sulfonylurea is IDF's recommendation as the first second line add-on drug to metformin. Now, the last 6 to 8 minutes, let me talk to you about these topics, or just a couple of slides in each. Do we have evidence that sulfonylureas work? I think I'll quote the advanced study where they try to intensify treatment with glycoside modified release, keeping the A1C below 6.5, and then another group, a standard group, in whom the A1C was kept 7.5. And you can see that as far as the A1C reduction to below 6.5% was considered, the advance, which was a little looser program or a controlled trial compared to the Accord, even in them, about 58% reached a target of 6.5 or below using a milder agent like glycoside. And you can see that there's not much cause of concern as far as the cardiovascular mortality is concerned. Again, if you quote the advanced study, there is not much of mortality, all cause, or from cardiovascular mortality if you use an agent like a safer sulfonylurea like, say, glycoside. And if you take, again, some of the actions of sulfonylureas on the beta cells, you have the specific action, the beta cell potassium channels, and also the EPAC2, both of which are important to produce insulin secretion. And glycoside is quite unique that it's quite specific for the beta cell potassium channel and not much for the EPAC2 activation. Now, what about hypoglycemia with sulfonylureas? Therefore, as I mentioned before, if you use a lighter or a milder sulfonylureas like glycoside, I don't think there's much cause for concern, because you can see in the intensive arm of this advanced study, per 100 patient years, there was only 0.7% of the prevalence of hypoglycemia. And even in this elegant study, which looked at patients in Ramadan fasting, comparing sitagliptin with glycoside, you can see that the incidence of hypoglycemia was lower with glycoside relative to the other sulfonylureas, and it was almost similar to that observed with sitagliptin. Therefore, glycoside is probably the only sulfonylurea which has similar hypoglycemia like sitagliptin compared to the other sulfonylurea agents. You can see the prevalence of hypoglycemia is almost identical in glycoside vis-a-vis sitagliptin. What about cardiovascular safety? This is a very elegant study done in Denmark, where they looked at about 100,000 patients, type 2s who were receiving monotherapy or any type of oral anti-diabetic agents, and they found that the cardiovascular deaths was definitely very insignificant if you use a sulfonylurea drug like glycoside. Of course, there has been some reports of mortality from glimepiride and glipizide. Now, what about nephroprotection? So I'll spend a couple of minutes on some of the new data on nephroprotection as far as this sulfonylureas are concerned. Now, this was the advanced study which was done in about 11,000 people for about 5 years and beyond. And these patients were put on glycoside plus epinephrine. So there were two arms of the study, the intensive arm and the control arm, as I showed you in a previous slide. But both the groups received equal amount of perindopril and indapamide. It is not that the group which got glycoside got more perindopril and so on. So both the groups got equal amount of perindopril and indapamide, but you can see that the reduction in patients who did not have any form of albuminuria, those who were normoalbuminuric, this drug, by using glycoside and bringing down the A1C to 6.5, the conversion from normoalbuminuria to microalbuminuria was reduced by about 9%. In patients who had some form of microalbuminuria or normoalbuminuria at baseline, the conversion to macroalbuminuria was about 30%. And you can see the end-stage renal disease. This is a significant point. The patients, about 30% of the patients in advance had CKD stage 1, 2, and 3, but the progression to end-stage renal disease was prevented in about 46% of patients by keeping the glycemic control to 6.5%, independent of perindopril and indapamide and the blood pressure control. So that's the important point. And this is a slide which shows you the 46% reduction in end-stage renal disease in patients who had some mild form of microalbuminuria or CKD, stage 1, 2, and 3, their progression to end-stage renal disease was sort of delayed by controlling their diabetes to an A1C of 6.5%. So this is the significant point which talks about nephroprotection. What about weight gain? Again, from the advanced study, we know that the weight change is hardly significant if you use a drug like glycoside or even glipizide and you don't produce much hypoglycemia, the patients don't put on weight. And lastly, about beta cell exhaustion, I think this is an article which Rory Hallman wrote, which many of you, if you have not read, I think you should read it, in Metabolism in 2006, where he made this statement based on his experience in the UK PDS. And Rory Hallman said that sulfonylureas are not associated with beta cell exhaustion or apoptosis. There's no solid evidence for beta cell exhaustion in the clinical setting over 6 years in the UK PDS. It was also suggested that diabetes may itself produce a decline in beta cell function. On the other hand, the cited desirability of DPP-4 inhibitors with respect to beta cell exhaustion is based only on extrapolation of short-term experimental data. So this is my last slide. So where do we place sulfonylureas in the Gliptin era? We have to remember that sulfonylureas are a fantastic drug to reduce the A1C. Just see the percentage reduction in A1C. It's 1 to 2%. So if you have a lean patient who is, quite hyperglycemic, it should work. The rate of glycemic control is 81%. The long-term glycemic control has been shown in studies like the advanced study. Hypoglycemia is uncommon if you use your drug judiciously and you and your patients plan out your meal plan and do monitoring regularly and so on. And as far as the comorbidities are concerned, I showed you data that there's a good reduction in albuminuria and end-stage renal disease. There's nothing too much to worry about CV death, and there's nothing too much to worry about beta cell function because all type 2 diabetics will anyway have a fall in their beta cell function over a period of time. And the therapeutic strategies with beta cell secretagogues, especially the agents like glycoside, have a proven good efficacy and safety in landmark trials, and it deserves special attention in day-to-day practice. I would like to thank you for your kind attention.